So welcome to today's ERA Journal Club. My name is Kate Stevens. I am a nephrologist from the United Kingdom. And I'm delighted to introduce our speaker today. So it's Frida Welander, who's from the Department of Public Health and Clinical Medicine at Umeå University in Sweden. And she's author of the paper Direct Oral Anticoagulants versus Warfarin in Patients with Non-Valvular Atrial Fibrillation and CKD G3-G5D, published in CKD. And on our panel joining us, we have two experts. So we have Sofie Dhaese, who's a nephrologist from Ghent in Belgium, and Gunnar Heine, who's a nephrologist and professor of internal medicine from Homburg in Germany, from Saarland University, although he's currently based in Frankfurt. So there's a couple of housekeeping rules to let you know of. The first is, if you have any questions, please put them in the Q&A and I'll do my best to put them to our speaker and our panelists. And at the end, there's a very short survey that comes up. If you fill that in, that's really helpful. It just takes a few seconds and it allows us to improve these sessions to give you what you want. So without further ado, welcome and thank you very much, Frida. I'll hand over to you.
So this is my disclosure of interest. First, I would like to begin by thanking you for selecting this article. And I'm happy to be here to present this on behalf of my research team. So, what do we know? Atrial fibrillation is highly prevalent in patients with chronic kidney disease. Up to 20% of patients with eGFR below 45 milliliter per minute have atrial fibrillation, and it's even more common for patients on dialysis. Patients with chronic kidney disease or dialysis have a high risk of stroke, and atrial fibrillation contributes to this risk, although it's uncertain how much attributable risk atrial fibrillation actually adds. These patients do not only have a high risk of ischemic stroke, they also have a high risk of bleeding, a risk that increases with decreasing GFR and is particularly high in patients on dialysis. In a general population, oral anticoagulants, OAC, decreases the risk of stroke with 2/3. Direct oral anticoagulants, DOACs, are proven equally or more effective and at least equally safe with less intracranial bleedings than warfarin. So can we extrapolate this to a CKD population? Well, in CKD G3, we can. These patients were included in the pivotal DOAC trials, and DOACs are considered equally or more effective and safe than warfarin. There have been no RCTs designed to study warfarin or DOAC in CKD G4, although a few patients were included in some of the DOAC trials. Warfarin has traditionally been used in G4, although RCTs are missing. DOACs are approved, not dabigatran, based on mainly observational and pharmacological data. This is a recent meta-analysis by Su. This study included data from the RCTs as well as from the observational studies in G3 to G4. And authors concluded that overall, DOACs had lower risk of thromboembolic events and bleedings compared to warfarin. In G5, patients with eGFR below 15, not on dialysis, warfarin is traditionally used. DOACs are not approved in Europe or the US. No RCTs have been made on OAC in G5, and only a few observational studies comparing DOAC and warfarin have been published. This figure comes from an observational study by Wire comparing rivaroxaban and warfarin in G4 to G5, showing no differences in risk of ischemic stroke and systemic embolism or bleedings between the two treatments. Regarding patients on dialysis, we have more data. Observational data is heterogeneous, with everything from less bleedings to more bleedings on DOAC compared to warfarin. DOACs are not approved for dialysis patients in Europe, but in the US, apixaban and rivaroxaban are approved for dialysis patients, and guidelines therefore differ. The European Society of Cardiology Cardiology don't give a recommendation about OAC for patients on dialysis, while the American Heart Association think it's reasonable with apixaban or warfarin to stable dialysis patients. However, 3 RCTs have recently been published. First, the Valkyrie trial by Dr. De Vries from Belgium was published in 2021, showing a lower risk of cardiovascular composite and less major bleedings on rivaroxaban compared to vitamin K antagonists. More recently, 2 RCTs comparing apixaban and warfarin were published in Circulation. The renal AF trial to the left was unfortunately inadequately powered to draw conclusions on safety and efficacy of apixaban compared to warfarin. However, this study highlights the great risk of bleeding in dialysis patients on OAC, with an almost 10-fold higher risk of bleeding than stroke. This study also demonstrated valuable pharmacological data of apixaban. The Exadia study to the right showed similar rates of the safety outcome comparing apixaban and vitamin K antagonists. However, this study too was underpowered, and this highlights the recruiting problems of RCTs in dialysis patients. A problem with these 3 RCTs, as well as all previous observational studies comparing DOAC and warfarin in CKD G4 to G5D, is the poor or not disclosed warfarin treatment quality in the warfarin comparison group. This leads to problems while interpreting and comparing the results. Warfarin treatment quality can be measured as time in therapeutic range, TTR, and Sweden is renowned for its high TTR, with over 70% in a general population. High TTR correlates with better outcome. Our aim was therefore to compare DOAC and well-managed warfarin in CKD G3 to G5D. We conducted an observational study based on data from our high-quality national healthcare registers. The Swedish personal identification number makes it possible to link data from several registers. We obtained eGFR from the Swedish Renal Registry, a register including patients from nephrology clinics in Sweden. The warfarin treatment was collected from Auricula, a register for atrial fibrillation and oral anticoagulants. The atrial fibrillation diagnosis was obtained from the Swedish National Patient Register, along with comorbidity data and most of the outcomes. However, the stroke outcomes were mainly collected from the Swedish Stroke Register. The Swedish Prescribed Drug Register provided the DOAC treatment, and all included registers have high validity and coverage. Moving on to methods. Inclusion criteria were non-valvular atrial fibrillation and chronic kidney disease G3 to G5D between 2009 and 2018. Patients were adults, not kidney transplant recipients. Exposures were time periods of DOAC compared to time periods of warfarin, and patients were allowed to switch treatments during follow-up and still remain in the cohort, and outcomes were analyzed in relation to current exposure and current GFR. The primary outcomes were ischemic stroke and major bleeding. Exposures were compared using Cox regression analysis with time-dependent covariates, and the covariates adjusted for are listed. We also did 3 sensitivity analyses. First, we compared only new treatments, excluding patients that were on OAC the year before inclusion, trying to assimilate a cohort of OAC-naive patients. We also did a sensitivity analysis excluding patients on dialysis, and a final sensitivity analysis comparing only correctly dosed apixaban to warfarin in G3 to G5. results. The baseline cohort consisted of 2,453 patients with a mean age of 76.7 years, and about a third were female. At baseline, 59% were on warfarin, and mean TTR during the study was 67%. 41% were on DOAC, where apixaban was the most common. The circle diagram demonstrates the distribution of GFR categories at baseline, along with the TTR distribution. Most patients were in G4 at baseline, and patients in G4 and G3 had a mean TTR of over 70%. About 9% of patients were in G5, with a mean TTR of 76.7%, and 17% were in G5D, with a mean TTR during follow-up of 60.9%. Mean time on OAC during follow-up was 1.8 years. This is a baseline table depending on a patient's first treatment. The GFR categories are marked with arrows, and as you can see, only 83 patients were on DOAC in G5, G5D at baseline. However, since a patient could switch treatments during follow-up, we know that a little bit more than 100 patients were on DOAC in G5, G5D during follow-up. Warfarin was more evenly distributed in the GFR categories. About 50% of patients had diabetes. Almost all patients had hypertension. About 20% of patients had had a previous stroke, and more than 50% had heart failure at baseline. And this was evenly distributed between the treatments. This figure shows the cumulative incidence of the outcomes depending on the treatment, with the warfarin in red and DOAC in blue. And as you can see, treatment periods of warfarin led to more major bleedings than treatment periods of DOAC, while there was similar cumulative incidence of stroke and death. The rates of major bleedings were high, with almost 10 bleedings per 100 patient years during warfarin treatment, compared to 6 bleedings per 100 patient years during DOAC treatment. The stroke rates were about 2 strokes per 100 patient years during both treatments. And notably, patients on dialysis had up to 10 times higher rates of major bleeding than stroke. Here is adjusted analysis of DOAC versus warfarin, showing a lower risk of major bleeding in all patients comparing DOAC and warfarin. As you can see, the result is mainly driven by treatment periods in G4. The risk of ischemic stroke was similar between the treatments. Of note is that the results in G3 differs from the results in the pivotal DOAC trials. This probably demonstrates a selection bias, since patients in G3 are only referred to nephrology clinics if progressive disease or if there's something special. And the patients in G3 in this study probably do not reflect a general G3 population. The risk of all-cause mortality was surprisingly a little bit higher during DOAC treatment. There was, however, not more fatal bleedings on DOAC, making us believe that the association is not causal, but this still calls for the need of further studies. The sensitivity analysis shows a very similar pattern to the main analysis, with a lower risk of major bleedings on DOAC, however, not in patients with new treatments. Ischemic stroke was equal between the treatments, and the high risk of death remains in the sensitivity analysis, except for patients on new treatment. Limitations. This study, of course, has many limitations, and the most important are due to the observational design and the use of register data. There are residual confounding present, and the most important one is probably confounding by indication. We do not know the reasons why a physician chose DOAC or warfarin. The group of G3, G5D is, of course, a heterogeneous group, and this calls for caution while interpreting the results, especially in G5, G5D, where there were few patients on DOAC included. Also, the stroke rates were low, and this was compared to other bigger American studies. Conclusions. High or moderately high TTR is achievable during warfarin treatment in chronic kidney disease, even for patients on dialysis. In this study, DOAC, predominantly apixaban, compared to well-managed warfarin, is associated with 30% less bleedings in CKD G3 to G5D, and the stroke risk was comparable between the treatments. DOAC seem like a safe alternative to warfarin, but further studies, preferably RCTs, need to confirm the possible benefit and if OAC at all is warranted in G5, G5D due to the high risk of bleeding. And that was all from me. Thank you.
Thank you, Frida. That was a great summary. Congratulations on your study. So we have had lots of questions in advance. And just to reiterate again, if you have any questions and are watching, please put them in the chat, the Q&A function, and I will ask them. But just before we get to the questions, I'd just like to go to our panelists. So Gunnar, I'm going to come to you first of all. Could you give me your thoughts on Frida and her colleague's study, please? Tell me what you think.
First of all, thanks for this nice data, and I think it's really good to have such strong national epidemiological data from Sweden, and you're lucky to have data that really comprise your whole nation. So when summarizing this, I would like to point out 3 points. So apparently we should not use vitamin K antagonists in CKD patients if these patients do not have mechanical valve replacement. Otherwise, your data clearly confirm that the risk of bleeding is tremendously higher than with NOACs. And the second note I took from this was that even with NOACs, bleeding risk is very high, and it's much higher than the stroke risk. And this also confirms data from other cohort studies and surely also from the randomized trials. So I think the next question that has to be answered will be, how can we get better alternatives? Because you saw a 10% or so risk of bleeding within 1 year in dialysis patients with vitamin K antagonists, and it was only slightly lower with NOACs. And so the questions for the future, and that's my last comment for the time being, would be, can we do better with occlusion devices? And can we do better when factor 11 inhibitors will be available in the foreseeable future? But thanks again for this great study.
Okay, thank you, Gunnar. So I'm going to come back to your 2 last questions in a second. But first of all, Sofie, would you like to pass comments?
Yes, thank you for your representation of your study. I think it's quite good you achieved such a high time within the therapeutic range, because I think this is a major limitation in other studies. I think mostly we achieve, or here in Belgium, we achieve approximately 50%, which is much lower than the 70% you achieve in Sweden. And so comparing DOAC versus warfarin is much more valuable when you have a good time within the therapeutic range. So it's a very strong point of your study. And regarding the bleeding risk, I think the question we all have is, should we anticoagulate these patients? But I think we still have time to discuss this later on.
Yes, I think that's the burning question, isn't it? So I would just actually echo what you've said, Sofie. So certainly in the UK, you know, our time in therapeutic range is probably lower than 50%, to be honest. So that's definitely a huge strength. So one of the questions that we got in advance follows on from what you said. Is any form of anticoagulation superior to doing nothing in patients on hemodialysis with non-valvular AF? So I'm not sure that we can answer that, but I'm sure you've got opinions about it. So Frida, come back to you, please.
Well, I think that is the key question. And I don't think we have the answer. I think we need RCTs comparing OAC and no treatment to answer that question. And my personal opinion is that some patients probably will benefit from anticoagulants if they have a high risk of stroke and a low risk of bleeding. And I also think we need better risk stratification tools than the SHAD-SVASC to decide who to anticoagulate or not.
Yeah, and so Jürgen Flög has actually written in the chat, he's wondered if you had any information on these patients, so patients who are receiving no anticoagulation, but I'm guessing the answer is you don't have any information on these patients.
What was the, can you repeat the question?
Yeah, so the most interesting dialysis group is people who are not receiving anticoagulation but have AF, and
yes,
you have any information on them, but I'm guessing that you don't have any information on that group.
Actually, we did a study comparing warfarin in patients on no anticoagulants, when the patients we gave warfarin had less stroke, but a higher risk of bleeding. So the conclusion from that study was that you probably should anticoagulate some patients with a high risk of stroke, but the risk of bleeding is very high in the dialysis patients group. So it should probably be only to selected patients.
Okay. Gunnar or Sofie, do you have anything to add to what Frida said before we move on?
Well, there has been a suggestion from Anne de Vries from Ghent, who suggested to give anticoagulation only to those people on dialysis who either already had an ischemic stroke or those who are, I think, older than 65 years and diabetic and do not had any relevant bleeding event in the past year. And I think that's for the time being a quite good suggestion, really, to reduce the number of patients who receive anticoagulation.
Okay. Sofie, what do you think?
I think maybe if you are in doubt and perhaps reduce those DOAC might be an option, I think, if you want to be cautious but still protect your patient. There is one study, I think it's called the Elder Care AF study in New England, who looked at patients that had a reason for anticoagulation. They all had atrial fibrillation, but they weren't eligible for full anticoagulation, usually because they were quite old, I think 80 years or older. And I think these patients received 15 milligram of edoxaban, so low dose. And what they saw was lower stroke risk, but no more bleeding. This was a small study, of course, but perhaps we should also look at different dosing in patients who we think are at risk for bleeding and whom we are not sure if we are doing something good.
Yeah, and so one of the other points that's been raised is there any way to monitor that effectively? So in somebody who's on a DOAC, is there any good way of monitoring how much we're giving them and if we are adequately or inadequately anticoagulating them, either too much or too little? Gunnar, let me come to you.
Well, we don't do that because if we believe in evidence-based medicine, then we have the DOACs with a strong advantage that we do not need monitoring. And we have all these trials, at least going down to creatinine clearance of 25 for apixaban, which clearly showed us that these drugs are better in most cases than vitamin K antagonists without doing any dosage control. So why should we go in clinical practice? And the second argument would be, I mean, if we would go for apixaban, we would give 2.5 milligrams twice a day. Nobody would give at least in Europe, twice 5 milligrams. And I guess nobody would go to one time 2.5 milligrams. So even if we get a result which would be above or below target, that in my personal view would not really change our dosing strategy.
Yeah, so same in the UK, we certainly don't monitor for the reasons that you've given. In Sweden and Belgium, is that the same scenario? You wouldn't monitor somebody who was on a DOAC?
No, we don't do that routinely.
Yeah. And Sofie, the same, I assume.
Either you don't do any monitoring. Yes.
Okay. So there's lots of questions. I'm conscious of trying to make this logical. I want to just pick up, Frida, you mentioned scoring systems. So Chad's Vask is what you mentioned. So we had a question in advance asking about scoring systems and what scoring systems people use in patients with CKD and patients on dialysis, and how appropriate we think they are for stratifying risk. So Sofie, if I come to you first of all, what risk scores would you use in clinical practice, and do you think that they're effective and they effectively quantify risk?
I don't think we should use JADS-VASc or HAS-BLAD or any other risk stratification tool we have right now in patients with CKD 4 or higher, because they simply haven't been validated in these patients. And the schedule Dr. Gunnar Heine already referred to from Dr. De Vries is something of a you can use, but it's experience-based and it's not evidence-based. So I don't think there's a reason to use commonly used stratification tools, but we don't have right now an evidence-based alternative. So I think this is work for the future, certainly.
Okay, Frida?
Well, we do use the JADS-VASc for patients not on dialysis, since this is the best tool we have. But for patients on dialysis, JADS-VASc perform poorly. So what we do in my clinic, we give anticoagulants to patients who have had a stroke or have other evidence of a really high risk of stroke, and other patients we don't anticoagulate, and we don't use other risk stratification tools either.
Okay, and then Gunnar in Germany, the same?
There's no consensus actually, but I think your data from Sweden confirm that whichever way we choose, we are not doing good, because again, we have 10% major bleeding per year. And this is the same in the randomized controlled trials. This is the same in the US American studies. So apparently, whichever way our colleagues are choosing their patients for anticoagulation, they apparently choose too many patients. Otherwise, we would not have this tremendous high bleeding rate with a stroke risk of 2 or 3%.
Okay, so let me just ask a couple of questions now about the methodology of your study, Frida, if that's okay. So first of all, from Amar Kambar, do you think that including the frailty score would affect the mortality endpoint? So if you included frailty measures in your work, or maybe you did?
No, we didn't do that. That's a good idea. Even though I think most patients will get really high points on the frailty score here.
Yeah, I think that's the point, isn't it? And then a sort of statistical question about the methodology. So Sofie Leabeuf says, congratulations for your work. And is a propensity score, could that be used in the study to try and reduce the bias? So if you use propensity scoring, do you think you could reduce the bias in your study?
We thought about doing that, but since patients were allowed to switch treatments during the study, we did not think that was feasible. So that's why we chose the Cox regression analysis.
Okay, perfect. So then let's go to some really practical questions. So Carl Lotta wants to know if you reduce heparin dosing during hemodialysis in patients who are on warfarin or DOACs. So I guess in your clinical setting. So in the UK, in our practice, we don't do that unless there's another reason to reduce the heparin dosing. What happens in Germany, first of all, Gunnar? Do you reduce the heparin dosing?
Neither do we regularly. It apparently doesn't work.
Okay. Is that evidence-based or just experience?
Gut feeling and experience by the nurses, because in most cases it's the nurses who do far better than us how to apply heparin, and in the majority of cases they tell us it's not really possible to reduce heparin either with vitamin K antagonist or with NOACs.
Okay, and then I guess in the interest of time, Sofie or Frida, do you do things differently? Do you reduce the heparin dosing?
I think we try to reduce it, but if it doesn't work, we don't.
Okay. And Sofie?
The same. Same.
Yeah, the same. Okay. So then I guess we've all been in this situation where people will sometimes start dialysis who've been on you know, a apixaban or a DOAC in the outpatient setting, and it's an anonymous attendee, but comments that it's difficult to discontinue the DOAC if somebody hasn't had problems, so they haven't had bleeding or they haven't had side effects, and if they've been on it for years, in inverted commas. So we've come across that, I think, probably all of us, with a number of different drugs. Do you have any comments about how you manage that? If somebody's okay, would you just leave well alone, or would you stop it? So Sofie, well, I'll come to you first of all.
Well, I think if they are on a stable dose and they're doing well, I don't think I would stop the DOAC. Perhaps I would reconsider when dialysis is started. But if they are stable, I think our practice is to continue the DOAC. Okay.
Frida?
Was the question if to stop DOAC in G5 or?
I think the question was, if somebody comes to if you take over somebody's care and they're on a DOAC before they start dialysis, but CKD stage 5, would you?
Okay, so we don't have patients on DOAC in G5. So if they're in G5, they're probably on warfarin, and then we routinely stop the warfarin if they start dialysis, if they hadn't had a stroke or a mechanical valve or something.
So you routinely stop warfarin in everybody?
Yes, right now we do, but probably things will change if we can use DOAC in dialysis patients. So, but that's what we do right now.
Okay, and then Gunnar?
Well, 2 years ago, I would have continued in most patients. I really changed the practice in the last 12 months or so, particularly after the 3 studies have been published. And now we participate in Dr. Eitel's LAA kidney study, and we try really to invite all patients to this study, in which patients are randomized upon an occluder or best clinical care. And therefore, we try really to bring more occluders to our patients.
Okay, so I think that's helpful. I think so in the UK we would tend to stop apixaban, just as you're commenting on patients. We wouldn't stop warfarin though. We would keep warfarin going. Do you think that if you were to strictly control everybody's INR, so that's not always feasible, I guess, but do you think if you had measures where you put in resource to ensure that people's INR was therapeutic the vast majority of the time, do you think that would overcome the risk of bleeding in dialysis patients on warfarin? Frida?
Well, no, I don't think so. I think it would probably reduce bleedings, but not overcome it. No. And we also have other problems with warfarin, as vascular calcification and calciphylaxis. So there's more problems than bleedings.
Yeah, and is there any evidence of an association with calciphylaxis with a DOAC or apixaban?
No, not that I know.
No, not that you know of. So me either. Gunnar, Sofie, you don't know of anything associating the DOACs with calciphylaxis?
No, I think the data are quite strong that it's really a vitamin K problem. And the other issue would be that there are also some data suggesting that renal progression is faster in patients on vitamin K antagonists. Surely this is not an issue for dialysis patients, but this is an issue for CKD G3 or 4 patients who might become dialysis dependent faster than those who are on NOACs.
Okay. Okay, so I'm just going to read you out Jürgen Flug's comment. So you remember he'd asked about the population who are on no anticoagulation with AF and how they fare. So he says, just another comment, maybe in a few years, we will no longer discuss all of this, watch out for the late-breaking clinical trial session at the ERA, where we, and in brackets hopefully, will present experience with F11A inhibitors in dialysis patients. They seem much safer in terms of bleeding than anything we have so far. So you're all nodding there. So Gunnar, I'm coming to you because you were nodding most vociferously. Would you like to pass comment on that?
Well, we are so grateful that we get this study or these studies, because there are a couple of companies who are developing these agents so early in the development, because we have discussed for years, for decades maybe, companies who produced the drugs, which are no longer NOACs actually, because they are not novel, but we have discussed for years with them to do some studies in dialysis patients, and after 12 or 15 years, we get some very small studies. So it's really great that we see larger CKD and particularly dialysis studies even before the factor 11 inhibitors are available on the market.
Okay, Frida, Sofie, anything to add to that? You can say no if you don't.
No, but I think it's exciting. So I hope the results will turn out well.
Yeah, absolutely. And Sofie, the same. You think?
Yes, I'm very excited, and also I think well, there are some trials still running trying to compare oral anticoagulation versus no treatment. So I think these results will also be very valuable. But for now, at least for what I know, there are no results yet, but these trials are ongoing.
Okay.
But they are ongoing for years, actually. So it's not a good sign if we do not get any news after 4 or 5 years.
Yeah, yeah. Well, it's been COVID, so you never know. There might have been delays. Okay, so then I guess the burning question from Peter Crisper: why do we still not have a randomized control trial of a DOAC versus placebo NAF in dialysis patients? So what are the barriers? Why do we not have this? Why is there not a randomized control trial of this? Sofie.
So the question was, why is there no randomized control trial in dialysis patients looking at DOAC versus no treatment?
Yes, versus placebo. Yes, indeed.
Yeah. Well, I think you need to wait for the SAC trial to tell us something more. And I think there's also a pilot study called the CKD trial, looking at apixaban versus warfarin versus no treatment, but this is only a pilot study. As my colleague already mentioned, we could wait forever, taking a long time, but still, I have some hope that there are some trials. So
just tell us about the SAC study then. The SAC study.
Study is looking at patients, I think, with CKD stage 5 and patients on dialysis, and they are trying to compare apixaban versus no treatment, and they're looking at stroke and major bleeding. Okay. But I don't know how far they are right now.
Okay, so to watch this space, and maybe the SAC study will answer that question for us. Okay, so we now have a comment about peritoneal dialysis patients. So do any of you, as our experts, have an opinion about the use of DOAC in peritoneal dialysis patients? So Gunnar, I'll come to you first.
That's a tricky question, because here we do have even less data than in hemodialysis. And surely there are 2 or 3 arguments in favor of going for anticoagulation, because these people are often somewhat younger, somewhat more healthy, and surely they do not go to hemodialysis twice a week, and they do not receive heparin regularly. So these are some arguments that might favor going for anticoagulation, but we have really no convincing data either to recommend or to not to recommend anticoagulation, in my opinion.
Okay, Frida?
Yes, I agree. I haven't seen those data.
So I guess if you had a peritoneal dialysis patient, would you be the same as a hemodialysis patient in that you would not prescribe apixaban, for example, to these patients?
Not routinely, no.
Okay. And Sofie?
I think we use it off-label, apixaban.
Okay, and do you know under what circumstances in peritoneal dialysis patients you would use it off-label?
Yeah, I think if you estimate as there's a high stroke risk. And again, there is no good risk stratification tool, but if your patient has suffered from stroke already in the recent past, I would prefer to continue, as long as it's safe, of course, and there's no major bleeding, I would prefer to continue the oral anticoagulation.
Yeah. Okay. So in patients who are not on dialysis, who've got a GFR of less than 15, so somebody comes under your care, I guess, for the first time, and they have non-valvular AF, they're not on any anticoagulation, what would you start? So would you start a DOAC or would you start a vitamin K? I guess I probably know your answer, but we've been asked this. I'm going to put it to you all. So I'm going to go to Frida first of all.
Well, I would try to include this patient in a study, but if a study isn't available, I think right now DOACs are not approved for G5, so I would probably start warfarin if I thought this patient was at high risk of a stroke.
Okay, and you wouldn't use a DOAC off-label in this setting?
Well, no, not yet. Even though I personally think that apixaban probably is a good option, dose-reduced apixaban. But since it's not approved yet, I would not recommend this. If I would prescribe it, I would do it off-label, and I would inform the patient that we don't know the benefit of this.
Yeah, I mean, we haven't really mentioned that very much, but I think probably the patient's opinion in all of this is probably pretty important, isn't it? Yeah. Presenting to them the different scenarios and the evidence if they're able to take that on board. Okay, Sofie. So you a patient who's not on dialysis, who has non-valvular AF and a GFR of below 15, what would you do? Warfarin or DOAC?
Well, I think I would be hesitant to start oral anticoagulation, depending on how frail this patient is, how likely this patient is to fall at home, these things. So if there is any sign that this patient will fall and do an intracranial bleed, I would be scared to anticoagulate these patients, especially because we really don't know what the attributable stroke risk is of atrial fibrillation in these patients. So when this is a frail patient, I would not do anything. So I would not start oral anticoagulation if this is a frail 80-year-old patient with a bad kidney function.
Yeah, I think that's probably true for most of us. So I guess that also lends weight to the argument that good risk stratification tools might be helpful. Gunnar, you?
I never start warfarin. I haven't done so for 10 years or so. No, but I mean, the majority of patients who are with their creatinine clearance or GFR below 15 will go to dialysis within some months or so. So it's really questionable if we say we're reluctant to go for anticoagulation in patients who are on dialysis. Should we really start, if these people are not yet on anticoagulation, should we really start now a DOAC for some months and then come back some months later when they are on dialysis and say, well, now it's better not to be on apixaban. So therefore, I'm also reluctant to start apixaban in these patients. And I mean, if we say, well, this is someone in whom we go for conservative care and would not start dialysis, then again, these are very frail people in whom we are not really sure whether or not they would benefit from apixaban.
Okay, fine. That's helpful. So I want to come back to you again. Sorry, I'm putting you on the spot a bit, but just because you alluded to this earlier. So one of the in advance questions was, is DOAC treatment in patients with CKD and atrial fibrillation nephroprotective? So you alluded a little bit to this earlier. Could you elaborate? And is there evidence? Hard evidence, I mean. So Gunnar, that's to you because you brought it up.
Okay, all right. Well, there are analyses from the large DOAC trials, in particular from the rivaroxaban trial, the RELY trial, if I remember correctly, done by Michael Böhm from Hamburg, who really showed that in the complete group of CKD patients who have been included into RELY, those who were randomized upon the vitamin K antagonist had a faster progression towards dialysis dependency. And this was when they then kind of split this complete group of warfarin patients into those who were rather below or above targets or within targets of INR, than those who have been above targets with their INR. In the majority of cases, they were those who advanced the faster towards dialysis dependency. But again, for the whole group, apparently it was better to have rivaroxaban than warfarin when it comes to CKD progression. This has not been confirmed actually with apixaban. So this is not fully confirmed, but there's some ideas behind it why it might be better to have NOAC than warfarin when it comes to kidney outcome.
Okay, and then so Frida, Sofie, do you think that the evidence is that warfarin actually accelerates kidney decline, or that the evidence supports that DOACs are nephroprotective? So Frida, I'm going to come to you first of all. So do you think warfarin accelerates renal function decline, or do you think that the evidence supports that DOACs might be nephroprotective?
I'm not sure it's nephroprotective, but I think it might not be accelerating kidney function decline as warfarin. So I agree with Gunnar.
Okay, and Sofie, do you agree also, or do you have anything to add?
I think there's only animal data suggesting that DOACs might be vasculoprotective because they might also have anti-inflammatory and anti-thrombosis capabilities, but this is only animal studies. And there are some more cardiovascular trials ongoing, such as the TRACK trial, and they are looking at, I think, rivaroxaban low dose for major adverse cardiovascular events.
Okay.
So yeah, maybe this will help us, but I think right now the evidence is not yet there. It's only animal data at this point.
Okay, it's not there, and no doubt the trial does not include patients who've got significant CKD, probably. Okay,
Yes, they do.
Oh, they do. Okay, so do you know down to what GFR?
In the TRACK trial, I think they include up to CKD 5.
Okay, well, perfect. That's good. Okay, great. So we need to watch this space. There's a lot of stuff that hopefully will come out to help. So I guess the talking about being nephroprotective is reminiscent of all the discussions around SGLT2 inhibitors and all these sort of newish things that we can now use in our patients. So we've been asked, do you think the decision to start anticoagulation, so DOAC, is truly that of the nephrologist, or preferably the cardiologist or general practitioner? So Frida, do you think it's your job, or do you think it's somebody else's job, or do you think it's a team effort?
Probably a team effort, but I think the cardiologist wants our opinion, so it's often we who start the anticoagulants.
Yeah, so that's probably similar in the UK, and I guess if we wanted input from cardiology in terms of what the risk was felt to be of stroke, etc., we might ask them, but they often ask us. What about in Germany, Gunnar?
Well, I mean, we always say we do not want to be only dialysis doctors, but CKD or nephrologist doctors. So we definitely should have an opinion here and not leave the field completely to the cardiologist. But surely it always also depends upon the local situation and how far the cardiologists are involved and how far the nephrologists. But in my opinion, we should really recommend dose reductions to our colleagues.
Okay, and Sofie, anything different in Belgium?
No, I also think this is a team effort, and the general practitioner is important as well, because often they know the patient from at home, they know whether or not they take the pills. So yeah, I think it's a team effort.
Okay, perfect. So then moving to another sort of very clinical question and a very relevant point. So we're talking about these different drugs and we're talking about numbers and bleeding risks and strokes. But Peter Crisper says that we often compare stroke versus major bleeding risk. Do we have any data about which event has the greater impact on a patient's quality of life? Which is obviously very important. So Sofie, I'm going to come to you first.
I think this is a very, very valid question. There was some professor in the Netherlands who told me that his mother had suffered from stroke, and he thought this was very bad for her life. I mean, she didn't do well after the stroke, and he thought she would be better off if she would have like a major bleed and all things were over. So I'm not sure which is more harmful, and I think we need to protect our patients for both ways, but we don't really know how to do this right. And I think the personal opinion of the patient, we should involve the patient here as well and clearly explain the risk of taking oral anticoagulation, yes or no. We should try to involve the patient and the family here, I think.
Yeah, I think patient-centered care. Frida?
Yes, I think that was a very good answer, that we should do this decision together with the patient. Stroke can cause both the morbidity and mortality, but a bleeding, of course, can do the same. So I think you need to weigh the risk and do this together with the patient.
Absolutely. Gunnar, do you think the same, or do you have a different take on it?
No, I do not have a different one. Maybe just for our colleagues who are not so familiar with the terms. So when we talk about major bleeding, it's in most definitions, those bleedings in which a physician is involved. So not all major bleedings are life-threatening or are affecting the quality of life. And this surely is different to the stroke, because I guess everybody would agree that a stroke of which kind ever will affect the patient's quality of life. And therefore, surely, when you kind to compare this, a stroke will be more important than a single major bleeding event. However, once again, 10% major bleeding is too much for 1 year.
Yeah, okay, that's helpful, thank you. Okay, so then a slightly different tact. Do we know if there's a difference in fracture risk when patients are taking a DOAC? And we know that the warfarin increases fracture risk in patients with CKD. So do we know if the same is true in patients who are on a DOAC? So that's from somebody anonymous. Frida, tell me what you think.
I don't know. I haven't seen this data.
Okay, Gunnar?
There are a couple of cohort studies which suggest that there may be less fractures in patients on NOACs, but not all cohorts actually yielded the same results. But it looks as if NOACs are better when it comes to bone health.
Okay, it looks like they're better. Okay, and Sofie, anything else to add to that?
No, nothing else. Thank you.
No, okay, so I'm conscious that we're almost at the end of our time. It's been a really lively discussion, so thanks to the panelists and Frida, and also to the audience. I want to come back to the measurement. So we all sort of vehemently said that we don't measure the efficacy of patients who are taking a DOAC. So Carlo Lamonti wants to know, is there a rationale for anti-TENI measurement in the dialysis patient, at least on DOAC therapy initiation? So the answer might be you don't know, because you don't do that. But so I guess if you had a dialysis patient who was going to start a DOAC for whatever reason, do you think there's a rationale for in these patients measuring anti-TENI levels? Frida?
I haven't thought about that. If I would measure anything, I probably would measure the DOAC concentration when after steady state. So that's what I would do.
But you wouldn't do that in clinical practice?
But I wouldn't do it.
No, that's fine, just checking. Okay.
Yeah.
Okay, Gunnar?
Well, again, we don't have actually an alternative dosage. So whatever we are measuring, we would stay with twice 2.5 apixaban. So there's, in my opinion, no real need in doing these measurements.
Because it wouldn't change your management. So if it was,
we do not have an alternative.
Yeah, you wouldn't increase. Okay, and Sofie in Belgium? Or in your practice, what would you do?
Yeah, we don't measure it either. And I think it was in the renal study, they had the pharmacokinetic data. And I think they looked at patients with bleeding and patients without, and they saw that the pharmacokinetic profile wasn't really too different. So I'm also not really sure how we would use this data if we have it. We wouldn't change practice, I think.
Yeah, so it's an intervention, I guess, that would give us information, but we wouldn't do anything with the information regardless what it showed. I think that's what you're all saying, which seems reasonable. Okay, so I think we're coming to a close. I just want to ask if any of you have final comments. I mean, it's a fascinating field. You can see there's been a lot of discussion. So often at these sessions we get good discussion, but this has really been a phenomenal amount of questions from the audience. So it's really a topical issue. What do you think is the most important question that we need to answer? I'm going to ask you all in turn. So Frida, what do you think is the most important question that still needs to be answered, and how are we going to get that answer?
I think the most important question is DOAC or OAC at all warranted in G5 and G5D?
Okay. So it's those patients on G5 and G5D, and we might get the answer to that fairly soon?
Yes, I hope so.
Okay. Gunnar, same question.
Yeah, I would like to make one statement that we did not address yet, because it's so important. We should never combine either vitamin K antagonist or DOAC with aspirin or other platelet inhibitors. Surely there are few people directly after myocardial infarction or ischemic stroke where you can discuss this, but I see quite a number of dialysis patients who come to us who have both anticoagulation and antiplatelet agent, and these patients really have a tremendously high risk of bleeding. So stop one of these two. That's not an answer to your question, sorry, but that's an important statement. I think that should be addressed.
Okay, so Sofie, you can either provide a statement like Gunnar, or you can answer the question. Up to you.
I think the other, aside from the stroke risk of atrial fibrillation in patients with CKD stage 5 or 5D, I think we also need a risk stratification tool. So we need to put a joint effort in trying to figure out what patients do we think would have a net benefit from anticoagulation, and what patients would we do harm.
Okay, perfect. And so then just to finish, so normally I'll let you guys finish, but I'm actually going to finish with a comment from Sofie Leboeuf again, who is talking about fracture and calcification risk. So just in case everybody hasn't seen it, I'm going to read it to you. So if she can comment about fracture and calcification risk from a pharmacological point of view. So warfarin has an effect on MGP, which is a calcification inhibitor, and osteocalcin by inhibiting the carbamylation via the vitamin K cycle. Whereas the DOAC action, or the OAC action, is a direct effect on coagulation factors. So in inverted commas, in theory, the DOAC has no effect on calcification and in fracture. And she says, thank you for this nice symposium. So we'll finish with a comment from the audience, unusually, but a helpful one. So thank you very much to you all. So Frida, particularly you, and your presentation was excellent. I think this is a terrific topic for discussion, and hopefully there's some answers to these questions coming very, very soon that have been raised today. Gunnar, Sofie, that was a lively discussion. So thank you very much to the three of you.